pretty face for this time. Okay, guys. Hi, everybody. Again, today's topic. Parham, we're doing what is it? Meth withdrawal.
So it's a meth detox timeline. Kind of how long does it take to detox? And my hope was, Doc, that you would be able to lay the foundation for some of the more acute detox symptoms, and especially what happens within the physiology, the body, and that kind of stuff, and kind of lay that foundation. And maybe I can come talk about some of the psychosocial stuff regarding anxiety and regarding possible treatments for it and all that kind of stuff.
Sure, we can. And let me set up my TikTok here.
And there's been a few questions already about Adderall too, regarding the similarities or the differences between the withdrawal from Adderall versus methamphetamines.
Yeah. Sorry. Absolutely. And I'm going to be obsessing over trying to find this, how to figure this out. But I'll get there. Okay, let me put this like this. All right, sorry guys. We will do this. Okay, all right, yeah, methamphetamines. Whatever, crystal, ice. Whatever people will call it nowadays. It is a major problem, and in fact, as I am lingering in my, let me just give a little bit of a historical on this, and just kind of set a really cool background here, because these things are always confused. So I'm doing a series on stimulants, and I'm really wanting to start on amphetamines and methamphetamines, and a little background about this. The reason, in some senses, the reason we have methamphetamines is because of what's commonly known as ephedrine, which in Chinese is Mao Hung, okay, which is the active ingredient in that drug. That stuff goes back 2, 3, 4, 5,000 years. And at some point, we started buying that stuff from the Chinese about 120 years ago as a decongestant, okay? And the search for a synthetic form of that, so that we don't have to, and this is a really condensed version, so we don't have to depend on the supplies from the Chinese, and later we discovered it in India and so forth, led to the discovery or the rediscovery of amphetamines by a guy named Alice at UCLA in 1928, although it was discovered earlier in Europe by some other guy. Eventually, when now we're talking about amphetamines, eventually that was kind of sold off. Initially, it turned out to be a real shitty decongestant, but they started to use it for a new thing they called mild depression, narcolepsy, diet medication. And during the same time, and World War II eventually led to methamphetamine discovery, synthesis, and so forth. And we're talking about Japanese, Germans, all this stuff. So it's very interesting how all of this stuff is in some ways related, and when you look at the history. But let's bring it to the present, the garbage that's out there right now. Methamphetamines. It's a huge problem. It's an international problem, in fact, okay? And we won't get into the chemical structure and pharmacology of this because there's, by the way, the synthetic stuff that you guys see out there, like bath salts and so forth, those are based on the active chemical structure of cathinones. And that comes from a plant in the Horn of Africa and the Arabian Peninsula from a plant named gat. And they chew it out there. So the synthetic speed stuff that you see, the designer drugs, comes from one plant from one side, and it's supposed to emulate things like cocaine amphetamines, methamphetamines. But methamphetamines really, in some ways, historically, comes from this search for a synthetic ephedra, Mao Hung, that eventually turned out to be, they looked for amphetamines, a guy in UCLA, and then methamphetamines. And here we are today. This stuff is a monster, right? Parham, as you know. And, sorry, crappy connection. Let me fix this for these guys. This stuff is a monster, and we don't have much of pharmaceutical therapeutic thing for it in the same way that we do for opiates. On the short term, it really, short and long term, it really affects several systems in the brain and neuro.
You'll be back. We will make him. We will get a good thing. So certain neurotransmitters in the brain, and he's going to come back and tell us the rest. But, you know, yeah, I'm reading the side chats too, and some of the history that he's talking about there is just phenomenal. Doc, we missed you for a sec. So when you were talking about certain neurotransmitters of the brain, that's where you were at.
Yeah, sorry. So, you know, it's structurally similar to amphetamines, and it affects several neurotransmitters in the brain. People often think of opiates as the one that affects dopamine. Well, this stuff puts opiates to shame in terms of the dopamine rush. And this is partly what is behind that reinforcing effect of the reward circuitry, because it's so gratifying. But then you're also talking about a couple of other neurotransmitters, including neuroepinephrine and serotonin. What happens is you really start to deplete this stuff. And when these folks come in, I don't have a personal connection to the withdrawal and the craving of this stuff, but it is extremely powerful, and it gets a powerful grip on these people. In addition, which way do you want me to go, Parham? I mean, are we talking about? Do you want me to talk about like some of the withdrawals early on, or what?
Yeah, exactly. Yeah, acute, and some of the post-acute. I mean, if you get into some delayed psychosis stuff, that'd be nice too, because some people don't know that without the use of methamphetamines during the detox process, there is a chance that a user might be able to experience post psychosis later on. You know, and that's an interesting fact that some people don't know.
Yeah. So when these people come in, oftentimes everyone kind of dumbs down the amount they're using. Number two, I notice that many users are already in a state where they've been hearing voices for some time, or have a certain degree of paranoia, and they try to hide it. That's number two. Number three, what you have to do in those first few days, and most acutely, you got to make sure there's nothing going on like rhabdomyolysis, right? Yeah, you know, a guy comes in on it from a meth run, you got to make sure, hey, what color is your piss? If it's Coca-Cola colored, his kidneys are about to go down. So you got to address that. So when they come in, you want to make sure they're very hydrated. Two, you want to make sure that if he doesn't feel like eating, he doesn't have to eat. You want to make sure he's hydrated. His body's going to tell him where he's at. He might want to sleep the next few days. There's going to be severe mood dysregulation. Okay, there's going to continue to be impulsive behavior, disruption in sleep, depression, right? And then there's that, again, that impulsive behavior with this stuff that really takes a hold of them. What I try to do is just really give clinical support in that acute phase. And I'm not really interested in starting too much medications. It's more like sort of like giving them that clinical support so they can sleep and just slightly start. And I just want to make sure that they're hydrated and they're not agitated. So I tell everybody, if he wants to sleep the next 5 days, let him sleep. And then I start my sort of assessment, and that's it in the most acute way. I mean, this stuff is so interesting, and we can talk about so much of this stuff, including the psychosis, the neurotransmitter depletions, and so on. How it's different from cocaine. By the way, this stuff stays in your brain much longer acutely than cocaine. It's man-made. Cocaine is plant-derived, right? Smoking this stuff causes a long-lasting high. Cocaine is a brief high. 50% of this drug is removed out of the body in 12 hours. 50% of cocaine gets out of your body in 1 hour. This increases the dopamine release and blocks dopamine clearance, okay? Whereas cocaine just blocks dopamine clearance, okay? It has a very limited clinical medical use. You can almost say cocaine has more uses clinically because you can use it as a local anesthetic for surgical procedures. I don't know. That's yeah. It's chronic use. What else? Its chronic use decreases appetite. Appetite decreases fatigue. Seemingly increases attention, wakefulness. There's a euphoria. There's a rush. But it has severe cardiovascular effects that can lead to heart attacks. What can really be called as a heart attack of your gut, heart attack of your brain, which is a stroke, hyperthermia, your temperature can go way up. So this stuff can cause a lot of damage. So I don't know. I'll leave it there, Parham.
No, that was great, man. I mean, it is a powerful drug, I'll tell you that. And the part that I want to talk about for each user that is experiencing addiction to methamphetamines or trying to get off methamphetamines, or if there's any type of, other stimulant, narcotic stimulant that we're talking about here, in that classification, we're talking about like the Adderalls and the illicit use of the Ritalins and the Vyvances and all that kind of stuff like that, which have some similar effects. Is my question to you is to ask the question of when and where did your use begin? So one thing that I've noticed and learned from working with a lot of individuals who are addicted to methamphetamines is then and there, when they were younger, and I'm talking about younger, I'm talking about maybe grade school, maybe junior high, as a result of their behavior, as a result of their inability to focus in class, as a result of their acting out, not following rules and just being unable to pay attention when they needed to pay attention, that some doctor, some teacher without any type of training makes a referral to a doctor that might not have that much training when it comes to this specialty, and prescribes them on a medication that at the time seemingly was supposed to help them. So, I've seen so many kids say, hey, before I started using meth, a long time ago when I was a kid, I was put on Ritalin. So this tells me that the human being using this drug, at some point in their life, they were unable to focus, they were unable to pay attention, they were unable to kind of follow the rules and all that kind of stuff. And here's the question. Why was that the case? And I'll tell you this. If you go back into their life, the environment that they were growing up in was in a way that they had a hard time paying attention to. So maybe there was some type of childhood trauma. Maybe there was some chaos. Maybe there was some loud home environment. Maybe there was fighting. Maybe there was an inability for them to pay attention. And then when you put them in school and the teacher's drawing on the board and you're wondering why the kid can't pay attention, it has nothing to do with the teacher and the board. It has a lot to do with what happened at home and the neurochemical brain development that happens in a moment-by-moment interaction with the environment. So the individual gets put on the medication. And by the way, a lot of kids that I've worked with or talked to, in the beginning, they have a hard time with the medication. It makes them feel weird. They don't like the way it makes them feel. They don't like the way they don't eat. They don't like the way they don't sleep, all that kind of stuff, but they continue to take it. And what happens is that eventually progresses to, they discontinue the use on their own sometimes. They won't take the medication the mom gives them, the dad gives them. And later on in life, they come across the illicit use of methamphetamines. And it's like Doc said, it's so powerful. It's so potent. It releases so much dopamine in the brain. It makes them feel, oh my God, I feel normal for the first time. I feel okay. I feel alive. I'm able to talk. I'm able to move. You know, the initial stages of meth use, it's not all bad. It's actually very highly productive and high functioning people are. So what happens at that point is then you get hooked on this thing that is so powerful and regulates and utilizes so much dopamine, you know, external dopamine, that when you discontinue the use of it, like Doc said, the cravings are one of the strongest cravings that exist in substances is the preoccupation of thought, the amount you're thinking about drug use, the amount you're thinking about meth. You know, no matter what you're doing, you're thinking about meth. You can't even imagine yourself doing the daily life things without meth in your system. And you can't even get yourself to come to that thought. So the most important part I want people to talk about when you're getting off this meth detox, and Doc's right, I've heard somewhere between 12 to 18 months it takes for the brain elasticity to come back after chronic long-term meth use. You know, so that includes anhedonia, that includes depression, that includes the inability to find pleasure in the things that you once found pleasure in. So it becomes really important for the person to start healing the brain. And how do you do that? Well, it doesn't happen in the first 7 to 14 days of getting off of meth. That is only the prerequisite for the real work to begin. And what do I mean by the real work? To find ways, to learn ways, coping strategies, to learn self-regulation of emotion, you know, through CBT, cognitive behavior therapy, through DBT, dialectic behavior therapy, to find ways to be able to self-regulate the mind. Because guess what's going to happen when you stop using meth? Besides the fact you'll feel depressed, besides the fact that you won't have any motivation at first, all of those same symptoms you experienced then and there when you were a child, they're going to come back and hit you right again. All the same feelings you had when you were an adolescent, they're going to hit you right back again. And that's why there's so much rebound anxiety. About 30 to 40% users that stop the use of meth, they start to experience significant anxiety. You know, they sleeplessness, fatigue, all that kind of stuff. So there has to be a well-balanced treatment regimen for this. And that's hopefully where we can start talking about some people coming in and talking about their experience, because if you're going off meth, man, it's not going to be easy. The depression that people experience usually takes them back to methamphetamines, or they'll start abusing other drugs. Doc, have you seen people get off meth and start abusing alcohol like it's going out of style? Have you seen that in the detox in our line of field in the early stages?
Yeah, and the younger ones I've seen that.
Like the substitution of one drug for another type of thing.
And the ones in the early 20s, poly. Yeah, I have seen a little bit of that.
Yeah.
You reminded me of. Sorry, it takes me a while to get going. But you know, there's other things that I didn't mention. You know, methamphetamine misuse actually it does lead to impulsive high risk behavior. 100%. You're at a higher risk for HIV, hepatitis B, hepatitis C. If you already have HIV, it makes the progression of the disease much more speedy. And I just things start to come to my mind, and I kind of want to mention it. This is the link hasn't really been established in the heterosexual population. It's very well established in men, homosexual men. Obviously, there's not enough data with the females yet. So this stuff comes with heavy issues. Parham, you mentioned something. One of the best ways to recovery, or rather getting your brain back online, getting your cognitive processing memory, and to decrease episodes of potential psychosis, whether you're using or you're actually in the clean stage, is engaging in behavioral mental health therapy. That's all that's been shown thus far. And so this is one that I really push that kind of engagement. It's almost like it keeps people grounded in reality. I think that's really important to mention on that. I don't know what else. We got someone here to ask a question. Should we bring him up?
Yeah, for sure.
Hi, Romero.
Hi, Dr. B. It's actually Romino.
Romino.
Oh, Yeah, I just saw that. I'm sorry.
No
Romino,
worries.
I apologize, Romino. Very cool name.
Thank you. I just have a couple questions about hallucinations, auditory hallucinations more specifically, and during like the phases of withdrawal. Sorry, I have a husky and he likes to talk. um, during the withdrawal stages, how long do the auditory hallucinations typically last? Because this individual decided to take the non-medicated route of getting clean, and it seems to be taking a toll on their psyche.
Romino, can you, I apologize. Can you tell me a little louder? I got crappy speakers too today.
Sure.
So, yeah, thank you.
I just want to know how long the auditory hallucinations last, how long you anticipate it typically lasting. The individual I know specifically decided to take the non-medicated route to get clean. So he's just experiencing the on and off auditory hallucinations.
When you say non-medicated route, is meaning to not get medication for
It's like
hallucination?
Yeah. It's just like NyQuil or DayQuil, things like that. Nothing like Xanax or anything of that nature.
Okay. So the question is, there's a particular person and you're asking, they're having auditory hallucinations, and at this point they're going clean, but they're having auditory hallucinations. Is that the correct question?
Yes.
Okay. So you actually, they don't get auditory hallucinations from the withdrawal. He was more than likely already having auditory hallucinations. Okay? And now it's potentially, again, unless if you know exactly what that person's doing, and there's only very few things that they can be doing that. But, and that's, if they can't tell the difference, if they don't have insight to it, it's kind of psychosis. So it's not the withdrawal in this case that is causing the auditory hallucinations. They were already there. So the question becomes, if they are trying to really go clean in those first few days, this person's continuing with auditory hallucination. And how long, I can't tell you. Most, it really depends on this person, how long this has been going on, and how bad it is. But if it's bad enough where it's publicly declaring itself, for example, to you, they would probably do better with medications at night to be able to sort of cope in this initial stage. Again, lots of hydration, and whether it's an antipsychotic or a benzo, both of those are really first line. You can actually quell so auditory and hallucinations with the benzos. And if that helps, I would go that route. But just understand that they didn't get there because they quit meth. They had it, and whatever is going on, it's you're aware of it now. So it must have been there before. Are you aware if it was there before?
Oh yeah, it's been there before, and I think this individual is because they have abused stimulants, just stimulants in general, for a while. They think that it may be just they have schizophrenia, but.
So that you brought up a great point. Psychosis in someone that seems to be presenting with methamphetamine use. And psychosis is the hallmark of the schizophrenia spectrum disorders, okay? And in this case, how should a clinician sort of go through and discern what is the cause of auditory hallucinations? And the way they do it is very meticulous history taking, right? We call history in a formal sense, we call it history taking, to really try and tease out what the heck is going on. Nevertheless, what is important to understand here is in those initial stages, it's irrelevant it's going to become relevant for long-term management of disease and understanding what happened in the historical precedent and how this person got to using meth. But at that moment, and you need a clinician. A good history can discern from a timeline of events and presentation. And sometimes this is extremely difficult because the patient is, just giving you a bunch of shit. And the family kind of, loved ones, it might be a girlfriend, it's hard. And I argue that it doesn't matter initially. If there's enough events in terms of psychosis and in a particular auditory hallucinations going on, that's going to impede the person's well-being, safety, and immediate recovery, I'm going to medicate them with the same stuff that I would whether it was schizophrenia as the original thing or this. There's psychosis, there's auditory hallucination, and it is symptomatic in a way that gets in the way of what the patient needs to do for safety and recovery. And the treatment's the same, whether it's extreme and they need to be admitted to a hospital on a 5150 or an emergency department overnight, or treating them at home, whatever that level of intensity is, it doesn't matter. The person has psychosis, and you got to figure out how long it's been going on and then get a good history to differentiate. And I made a video, I think, talking about some of this. I can't recall. Does that a little bit, Parham? Do you have anything to add?
No, I kind of like the direction you were heading about making sure you get a pure history. What I mean by that is a biopsychosocial assessment, a mental health assessment, because I'm not saying this specific individual here, but when I go through those, or when my team goes through those, one of the things that I notice that is frequent, not always, is frequent, is you look at the history of medication compliance, and you look at the history of what was prescribed to this individual, when was it prescribed, why was it prescribed, any type of co-occurring disorders that might be here, anything along the bipolar spectrum of things. Because what happens is a lot of commonalities tend to appear when you look at a history, because I've seen so many people, Doc, and you've probably seen this too, that get prescribed a certain medication, maybe an antipsychotic or something, because of the symptoms they're having of actual going through schizophrenic, hallucinations or delusions, and they get put on a medication and it completely takes them away. We hear this all the time. It takes away my ability to think. It makes me feel like I'm in a fog. It takes away my meanness. And that person gets off their medication, and not only gets off their medication, they tend to get on a amphetamine type thing, whether it's methamphetamines, and now they kind of, it's fuel on the fire. So now there's some possible underlying causes of the bipolar with schizophrenia going on, and then there's drug-induced psychosis going on. So I'm 100% on your approach that in the beginning, it doesn't matter whether it's drug-induced or it's underlying mental illness that's been there long before. The most important part is being able to allow the person to rest, get hydrated, to sleep, to feel safe and comfortable. And later on, that's when the clinical team can come in and say, okay, what are we looking at here? So I've seen delayed psychosis all the way up to like 8 or 9 days post the stop of meth, to be honest. That's as furthest I've seen it. And I don't know if I'm sure there's cases that go beyond that, but you got to get through the initial stages first. So that's kind of what I had.
Yeah. And, up to 40% of methamphetamine users in the lifetime of their use will experience this for a certain amount of time. And when your psychosis is secondary to schizophrenia, we call that primary psychotic disorder, and anything else is secondary, including substance abuse. But like I said, all of that stuff is regardless. Right now, the symptoms are the symptoms, and sometimes it takes a while. You got to interview the mother, a history of this stuff. Ours is not as, I think the biopsychosocial is very, very extensive. Ours is much quicker. And then actually, if you do this, the biopsychosocial, then you can really dig into stuff. But so you got to make sure that the initial thing is addressed so he's not dangerous.
Thank you, guys.
Does that help?
Yeah, I think it more so has to do with compliancy from the patient or the individual himself first. He's really good at hiding the auditory hallucinations from everyone else. Is just comfortable with me, so I'm able to see it. But I think compliancy is first.
Okay. I hope that helps. Be cautious, and we wish you the best.
Thank you.
Thank
Okay.
you.
Bye. Bye. That was a great question.
Yeah, absolutely.
Let's see what we got. Hey. Oops. Man, I'm a mess today. I just killed the TikTok folks too.
Hey, it's one of those days, Doc. It happens to the best of us.
Oh my God. I just plugged it back in.
You know, SAMHSA did create something for anybody that's kind of wants to get exposed to some of the cognitive behavioral stuff. You want to go through this with a clinician or a therapist, but there is a free resource on the SAMHSA website, which is samhsa.gov, and it's called the Matrix Intensive Outpatient Model with people who have stimulant use disorder. So it's for people that are addicted to methamphetamines. It goes through like page by page, and it's just such a wonderful interactive handbook. It's a free resource to use, preferably with a clinician, but if that's all you have in terms of resources and you just want to keep your mind occupied in the early stages, it's a wonderful resource. It's called the Matrix Model for Stimulant Use Disorders.
Is that the book that's like 100 pages?
It's 114 pages.
Yeah, I really like it.
Yeah, and they have one for families also, for family education, for families that don't know anything about addiction, stimulants, all that kind of stuff. It's a wonderful guide through family education and support.
Oh, I did not know that. Should we bring it on, Vince?
Sure.
Hi, Vince. Vince?
It's streaming. It seems like it's loading.
Okay. Every week I got some crappy complication.
You just got to get it set up and not touch. Like, you have to have like one station that's just for your live streams, I think.
Yeah, the problem is I share equipment with the stuff for other stuff, and I will. There's Cash. Should we give Vincent a minute here?
Yeah, I mean, we can get him back. He can just be the next in queue.
Okay, Vincent, we'll get you right back up. Dash, what's up, buddy?
There he is. What's up, Cash?
Hey, everyone. Can you guys hear me?
Yeah, perfectly.
Oh, nice. Hey, Dr. B.
You look fantastic.
Thank you. Hey, Parham. I haven't met Parham. Wait, I'm hearing.
Do you have this open on YouTube also? Turn off your YouTube.
Sorry, I was hearing an echo of my own voice playing from about 10 seconds ago.
If you turn off your YouTube, it'll go away.
Oh, okay, there we go. All right, now we're good. Hey, okay, so I just wanted to say this is not a paid plug or promotion in any way. I'm not getting paid to say any of this, but Dr. B and his staff and everybody in Orange County literally saved my life. So for the people that are on the live stream, I can't encourage it enough. Just to reach out and ask for help if you need it, and you'll be surprised. I'm 32 days sober now, and I haven't been sober since I was 19 years old. So I'm 29 now, and it's been like the craziest 32 days ever. But what started it was actually reaching out to Dr. B and just, you know, giving up, giving in, being vulnerable, and then it's so worth it on the other side. The other side is so much better. But my question is, and sorry, I don't want to keep going on and taking too much of your time. I did definitely want to reach out to Parham to see if he could help me as well. But my question is, I was prescribed Adderall for almost 2 years for weight loss. And it wasn't my drug of choice, but I'm worried about the long-term consequences on my psyche. I feel like in some way, because it gives you even more dopamine than heroin would, I feel like the long-term consequences might even be worse. So I just want to know, like, in 2 years and 3 years, will my brain recover from using Adderall? I haven't used meth, and the Adderall, I never crushed up or snorted it or anything. I just took it more than prescribed, but it was prescribed for weight loss. Sorry, I'm really nervous. I hope that made sense.
It did. Doctor, go for it, Dr. B.
Yeah, gosh, thank you. You're kind, and you didn't have to say that. I was just going to comment. You look amazing. I actually haven't seen you in a couple of weeks live, but Paul tells me stuff, your face and stuff looks different. And the other thing is that since you said it, I'm going to say it, and it's him. It's not me. My team is amazing. They do a great job, and they carry everyone through. But one of the things Cash has done himself is one of his major issues, Parham, has been he has some anxiety and is extremely shy. And that's why one of the reasons he would never reach out. And when I saw him on here, I'm like, oh, Cash. And I saw his face. I'm like, well, he can't possibly come on because he's described this issue to me. And he popped on here, and he doesn't look nervous at all. And in fact, I can tell you've been clean 32 days. So you're a badass, dude. And we love having you. And you give us just as much. But you got to give yourself some kudos on that. The Adderall, a complicated question. Look, it's a question of risk versus benefit, okay? And you know, I'm not going to mention it on here. I think the doses that you are on are quite small, and if we start off with I don't want to give you because sometimes the data is really clear on something, okay? So I can say it. I don't want to put myself in a position where the data has still to be sorted out. But I will say this. On more than one occasion, I have seen people present to psychiatric emergency. I used to run one many years ago. And we had this room. And this room, and this is a county facility, was sort of our padded room. And if you can imagine, in the 2000s, and there's a window, and they'd be in there, and the security would just be outside watching. And whenever I got a chance, I'd go say hi after a resident saw them. And you'd always see someone in a psychotic break in there doing whatever. Every once in a while, this is after seeing hundreds and hundreds of these folks, every once in a while, I'd walk by that window, which had been pretty tore up from many years of people throwing feces on there, punching it. Every once in a while, you'd walk by and you'd see someone in their 20s, 30s, 40s, and they were dressed quite meticulously, which is not what the average patient that would present there was. And they were sitting there, you know, eating their own feces or slamming their head against the wall. And I already knew what it was. They were having a psychotic break from long-term Adderall use or any kind of one of the prescribed amphetamines. Okay. and usually on the higher end, oftentimes 30 milligrams 3 times a day, so, crap like that. Having said that, it is a stimulant. It is a drug with a high potential of abuse, and it does have profound cardiovascular, long-term use can cause pulmonary hypertension, MI, strokes, which are all the same things meth does. If you're going to take it, you have to take it for the right indication. Now, do I think it's going to eat up your brain and I think it's a pretty low dose in the next couple of years? No, right? And I don't know if you actually have ADHD, ADD spectrum disorders. I'm a big advocate of this stuff. This is what people don't understand. They're like, well, how come you said that, but then this? It's risk management with any medication a physician gives, and they should take that seriously, right? I have another, someone that I know that has an autoimmune disorder. They're severe ADD, but because if they take the stimulants, Adderall, whatever, it shoots their blood pressure up and has profound effects on their autoimmune disorder. We're stuck between a rock and a hard place, right? What do? Right? And this person has chosen a different route with a very extreme consideration of their diet, mindfulness techniques, meditations, etc. So it's a risk benefit. And in your particular case, assuming there's no ADD, ADHD, I think it's best that in the long run, you come off of it and start to do some of the other things that we've been discussing. I've been pushing, the soda issue, and you just look great. You look so focused right now. Soda issue, diet change, exercise. And I'm a big fan of all of that stuff right now. So I don't think you need to worry. But at your age, there's no reason for us to be on this for the next 30, and I'm not the one prescribing it, I don't think, but next 30 years for weight loss, it was the wrong thing to do. That's my thoughts on it. I can't tell you if it's going to eat up your brain the next couple of years. It's not. But I can tell you that effect is sort of a dose-dependent and additive. And why would I want to have someone that's had a substance abuse problem on this crack if they don't need to be?
It's interesting that you think 30 milligrams 3 times a day was a high dose, because that's what I was prescribed. But towards the end, I would take an upwards of 160 milligrams one time, and then it would last about 3-4 days. And then, you don't sleep during that time. You barely drink water. But yeah, that was I'm assuming that's got to be just as bad as meth is.
Potentially. And it's funny you said that, Parham, back in the day, if you look at the doses they were prescribing even for ADD, much, much smaller than this. And I see these, I have a couple of people on this stuff. And I think the highest dose I have somebody on is, 20 milligrams extended release every day. And that's it. So, yeah. Parham, do you have any feedback?
I'll share something here, Cash. I'm not going to talk really about the impacts of the brain of Adderall. I'll talk a little bit, completely different perspective. You ready? So, in my opinion, when somebody goes and you got prescribed Adderall for weight loss, right? So I'm just going to go in the mindset of someone that goes into a doctor's office and asks, hey, doctor, I'm struggling with my weight. I'm struggling with the way I look. What can I do for my weight loss, right? So if you just start the video right there and all of a sudden you start rewinding the tape back, now the important part for me becomes, Cash, as you get sober right now, congratulations on your 32 days and you move forward, is like the underlying causes of like the self-esteem stuff, the underlying causes of like the impact of feeling like you were overweight for probably extended period of your time, the underlying causes of how that like how that experience was like for you growing up, you know what I mean? Or whenever that was, because not everybody just rolls up to a doctor's office and says, hey, give me a pill to lose weight, right? That's like the last resort. I'm talking about God knows how many things you tried until you got to that moment in your life. So in order to kind of really recover and heal from this, you got to look back to where it all started, of when you started to feel like your weight is a problem for you. And you really do look great right now. I'm not saying this is current time, but I'm saying if you go back in your history, I promise you there was some moments like that in your life. And those moments, how did they impact other areas in your life? Because most people just don't seek out a doctor for weight loss with a pill, right? That's like a last resort type thing. So, and then doctor's right, man. You want to look at your lifestyle right now. There's one thing you got to change about your lifestyle that got you here, and that one thing is everything, right? So you want to look into nutrition. You want to look into health. You want to look into your outlook, all those kind of things. Because if you don't change them, you're going to be that same person looking for a way to fix your physical health problems. You know what I mean? And it's a never-ending cycle. So that's kind of my perspective on this thing.
Thank you.
I can tell you, it was almost hard to recognize you because you could see through your eyes. But we've talked about this, and I didn't know Parham until a few weeks ago, where we did this thing with Parham on exercise and nutrition. And most of us physicians, we almost always, in passing, give a tongue-in-cheek thing like, yeah, you need to drink water and eat well and exercise. And I've always sort of known, but I've had some of my own personal experiences recently, and Parham knows about it, that I am dead serious. In fact, without sounding like a fool as a medical doctor, I want to say this stuff is the cornerstone of changing one's life. Your diet, your nutrition, and exercise. And that's why I pushed you when we were talking about. And we gotta. Do you have are you seeing me soon?
Yeah, this Thursday. If you're in the office, I saw. Sorry, I'm blanking on her name.
Alexis?
Yeah, I saw Alexis last week.
Good. Yeah, she told me because she called me afterwards. But I want to see you because the stuff that Parham was saying, I really want to kind of get you, because look, if you've taken down this road, it's not. I always say it's a monkey could get you off the drug or prescribe you a medication, but to change your brain from one of an addict and set you up for success in life and coping skills, that takes a clinician with some, it's work. And I don't see you have. Yeah, let's see you on Thursday and follow up on this.
Okay, thank you guys so much. I'm gonna go back to listening then.
Okay.
Thanks, Cash. Appreciate it, bro.
All right, thank you.
Bye, Cash.
Hey, Doc, I got a quick question on. Do you know anything about the pill that got kind of banned? It was called Fen-Phen, and anything related to like pulmonary hypertension or problems related to the heart. Is that something that's kind of cycled out? Because I remember people used to abuse Fen-Phen for weight loss significantly.
Yeah, it's phentermine, I guess. But was it in Canada that the Fen-Phen still had problems? Is that where it was, or was it?
Yeah, I think phentermine is like a newer version of Fen-Phen, right? I think the original Fen-Phen.
So here's my point. They all can cause pulmonary hypertension.
Okay.
But with Fen-Phen, was the issue in Canada or was it here? Do you remember?
Mine was the U.S. I remember it. They were prescribing it to everyone for weight loss.
Yeah, and I read some issues with the Canada. Yeah, I mean, this stuff is it's basically stimulants, and I think a whole bunch of people came down with pulmonary hypertension, which is a nasty thing to have. What is your question in particular? It is an amphetamine. That's what it is.
Yeah, no, that was just the question about the correlation. If it is an amphetamine and the correlation with pulmonary hypertension, but that's what I thought it was.
And you know what? Do you ever see that movie? It's a movie I really enjoyed. Oh my God, Requiem for a Dream. Did you see that? And remember the mom, the older Jewish mom, who was. So that whole side storyline in there was about mom going to a doctor
Yeah.
and basically getting fentanyl, and she started inhaling it, and she actually went into psychosis because she was having delusions and auditory hallucinations, and that's psychosis. And
Yep.
so same thing.
Absolutely. Yep.
This is such a great topic, and oh my God, it's 6:07. Let's get Malik in here. Guys, I think I have about 10 to 12 minutes, but it's been well over an hour because I got to go check on these patients. Hold on. Ready? Should we get Malik in here?
Yeah.
God, I really like this topic. I got to change my clinic schedule here because I'd like to keep going on this and get it up to 2 hours. Hi.
It's kind of it's doing the same thing the other gentleman was doing. It looks like it's just buffering, loading.
Yeah, and Vincent's is messed up too because he's like, it says device not connected now. Do you see anything you want to answer? We'll leave Malik up for now.
Trying to see. I mean, there's a lot of people just interacting with each other. Not too many questions. If anybody has any questions, we can take some right now. I know you're engaging with the community, which is what we like, by the way.
YouTube, TikTok, guys. And I'm sorry, my connection is even crappy on TikTok. I screwed them too. What are your thoughts on baclofen? In what way? I like baclofen, but it can also be a substance of abuse. Yeah. If you're asking me baclofen for spasticity, I actually think it has a pretty clean profile compared to some of the other antispasmodics. If you look, they always use baclofen pumps on quads. That being said, even with baclofen, you have to be cautious. 2 can turn into 3, can turn into 4, and it needs to be taken with some consideration on that. But other than that, I like baclofen, and I usually use it on not everyone, but it's one of my armaments.
I think we got Malik here. It seems like he's connected.
Hi, Malik.
I thought it was.
Yeah, it is. Looks like it.
No.
Malik, talk to us. Okay. What do you think? I am traumatized from rehabs in Mexico. They treated us like garbage. I'm sorry, Veronica. Oh, Parham, what do you see?
Yeah, I'm sorry about that too, Veronica. It's I don't like hearing human beings getting treated like garbage, whatever country the treatment center may be in. I hope you continue. I hope that doesn't discourage you to continue finding recovery, continue finding a healing space for yourself, and maybe if you can't find it where you're at, interact with this community. There's a lot of people on the side chat, Veronica, that'll be able to at least treat you like a human being and be able to support you. Might not be in person, but it might be just here. So, yeah, do whatever you can to find some good help. I know it's hard to find some places, but where there's a will, there's a way.
Likewise, Veronica, if we can help you in any way, let us know. Parham, one thing I do want to mention is I think I made a small video on this at some point, but I call it, and it's worth mentioning, and you've probably seen it a million times. I don't know. I call it the methamphetamine trap. And over and over again, I may see somebody, and it might be in the clinical office or the outpatient, I'll see somebody for primary opiate use, so, heroin or whatever, fentanyl. And then you ask them what else you use. And tell me how you've handled this, and I'm sure you've seen this. And they're like, meth too. I'm like, And there's this knee-jerk response. Oh, I don't have a problem with meth. I just use it sometimes with that. So I get that, and you're like, okay, just tell me how often you use it. Every day with your heroin, 3 days. I just here and there, and you never get a really clear answer. And I made a little video about this, and they're being genuine, many of them, right? And the use starts to escalate and creep up on them. And since we are on this topic of in general methamphetamines, I would like to give all those out there in this situation a stark warning. Don't add another monkey on your back, man, right? This thing is messy, right? And sure enough, next thing I know, I get the opiate issue under control. Now I got to deal with the meth issue, right? Parham, tell me, you laughed, so give me your thoughts and feedback on that.
I've seen it, and what happens, I think, with the use of meth, at first it's such a powerful drug that the smallest amount of meth use gives the most prolonged effect. What I mean by that is the smallest amount of meth allows the individual to go 6 hours, 12 hours, 18 hours of energy. And you give that to a human being that's really struggling with other addictions. Maybe they're down and depressed because of their alcohol use or their opiate use or their heroin use or their fentanyl use. And all of a sudden you add that to them. For them, it's like, oh, I get to finally function. I get to finally be normal. I get to finally do things. I'm able to be a part of society. And they really minimize the impact that it possibly can because they're actually so productive with it. And, it doesn't have a physical dependence, especially if you're using other drugs. You're not physically dependent to it. So you're not so terrified of the withdrawal. I've seen it come in binges. I'm sure you've seen this, Doc. Someone can go, maybe 7 to 10, 12, 14 days without using it. Then all of a sudden they go 3 days straight on the meth. Or 3 days straight, kind of similar with cocaine. You've seen those binges with it, but it's really subtle, and it's to the point that they don't see it as the primary reason that's destroying their life because they're using another drug with it often, in that regards. But I have seen it. I have seen them downplay it until it becomes their primary drug of choice, and I've seen that happen, their switch, and it becomes the most demonic chokehold on their life that they've ever experienced. I mean, I'm talking about, you've seen the faces of meth. You've seen what it does. I don't think there's a drug that does that to the user in terms of the physiology, the mind, the body, the spirit, the soul, the teeth, the eyes, the skin, the hair, the nails. I've never seen anything do what meth does to people, firsthand experience. And that's not the experience they have right at first. It's just like a casual acquaintance. Then it becomes their abusive lover.
Yeah, you nailed it. And it's funny, that because this stuff, and it's partly because it's so garbage nowadays, it just, I'm often asked, it just tears them up inside out physically. And I think part of it is the quality of this stuff. And it takes a hold of them before they even know what happened. And there's Vincent again. We'll get you up in 1 sec, Vince. The other thing I've seen here is, one of our person that runs one of our programs here, she was talking about it in terms of females, but there's a few homeless people that I deal with regularly and I take care of, and I have come to really understand it's often used in that population for safety. So and then it becomes a problem, right? I'm sure you've seen this, and females on the street use it for safety, and I mean in terms of staying awake at night. So there's these sort of psychosocial dimensions of substance abuse seen because of the dynamics that people have to live in their individual lives. And it really points out to the complexity of substance abuse and how it's marginalized. I mean, if you have a homeless guy using it just for safety, there's so much that needs to be addressed there. And that just kind of came to my, oh man, we lost Vincent again. That just came to my mind since we're talking about this. Have you seen that as well with the homeless?
100%. Yeah, I've heard a lot of homeless populations say they use methamphetamines because they want to stay up on hypervigilant at nighttime. They're just terrified. I've also heard people who work graveyard shifts, oddball shifts, you know, in terms of they're awake when the rest of the world is sleeping. I've heard them abuse this medication or this illicit drug. I've heard it with, I mean, you know, the truck drivers, right? People that go on long extended drives. Truck drivers use it, and it becomes a way of their life for functioning. Not all truck drivers, obviously. You know, they get drug tested pretty regularly. So I'm overgeneralizing, but there are a subcategory of those individuals that find ways to abuse that. And I think you've talked about this too, and I knew about this. Was initially like was it World War II that all the soldiers were using it for combat to be able to stay awake? And
yeah. So it's funny. Yeah, you say that. And I didn't want to get too much into it, but there's always this joke that basically, I don't remember what one of the battles was. You know, the Germans basically copied the Americans on this. And one of the famous battles, you know, there's sort of a joke in those folks that know what's going on. It's like, you know, it was meth on meth, right? Yeah. And they had these poor guys tweaking. And yes, it was. You're right. World War II, and that itself had quite a profound set of consequences as well. Yes, they used it there as well.
There's also, Doc, there's also a circle of, I mean, you're an academia guy, and you come from prestigious university systems. Even in the high school world, where I kind of you know, dabble with coaching high school sports and all that kind of stuff, there is a subculture of extreme academics that youngin' kids, I mean, they might not get hooked on the meth, but they're getting hooked on the Adderall just to stay competitive with studying in order to get to certain places. And again, this isn't, I'm overgeneralizing people. I'm not saying all students with good grades do it, but there are some students who have the external pressure to keep up with the demands of the workload that tend to do it in high schools or even major universities.
In fact, what you say is such a huge issue, especially when you're at the college level, that there's extensive literature on it, whether it's in sociology, substance abuse, psychology. There's extensive literature on just what you said. And so think about the social context, the society that we're in, where something is wrong, right? Where you know, that college student, and like you said, it's not everybody, but the college student, this has become, I wouldn't say normal, but it certainly is in the repertoire of the choices you make to stay competitive in college, and something's wrong there. I really protest to this kind of attitude, but you're not off. It's very much, in fact, the case.
Yeah,
it's a lot of stuff, and I should mention, you know, there's a lot of reports that methamphetamine misuse abuses has been on the decline. That is not so. Look in some areas in Hawaii. Look at some of the areas in central U.S. and the South. It's quite endemic, and one of the populations that it has a heavy impact on, which really is something I'm quite interested in, is the pregnant population. And really, these people, those kids, end up having shitty outcomes. We've been talking about the ACEs, and it's not even necessarily the drug that causes certain particular outcomes. And I can even say that it can even be argued that, you know, the particular outcomes, as they are directly related to the drug, or some of them are not clearly defined. What I can tell you that everybody agrees on is this: in the same way that that lifestyle causes risky behavior, increased HIV, et cetera, that lifestyle from the mother causes situations and inciting factors, or lack thereof, where it sets the kid up for every kind of failure, including cognitive development issues, ADHD, I mean, you name it, poverty. So this is one population that meth has a really, really negative impact on. And, something should be done about that as well.
I know you got to leave right now, but you just talked about how meth, they say, is on the decline, but there are certain parts or certain demographics or groups that's not the case at all. There's another one that I'm a little passionate about, is actually the Native Americans. The adult males, usually they're synonymous with alcoholism and drinking alcohol and stuff like that. But their youth, the younger generation, on the reservation, on the res, where there is extreme poverty. I'm talking about, it's just situations that it would not make sense to the general population of the U.S. to understand. Methamphetamines has a chokehold on the youth over there. I mean, I don't have the data to support it. I just know for a fact by being a guest there and just taking a tour and seeing the damage and destruction. And, they even have signs it's so sad, but it says, "Don't meth with my kids." It's like "Don't mess with my kids," a play on words on that. But it's to the point that it's saturated in the community, which is really sad.
Yeah. And I didn't even talk about that population. And sadly, well, I think it's all over the place. The gambling money has done them a lot of good, and I think it has perpetuated quite a bit of harm. Again, it's our lifestyle, but that's another population that needs a lot of help. Whether they're starting to get a lot of money or not, there needs to be a lot of assistance in many ways. Let me see. I think Mamalo's talking to me. Dr. Bob, love your videos and content. All right, hey guys. If you want a question, I'll stick around 3 or 4 minutes. Again, my glasses aren't there, and I appreciate all the positive stuff you guys are giving me in Parham. God, an hour and a half just flew by, Parham.
Yeah, man, it's okay. We're having fun. We're having fun. We love doing this, everyone. I hope you guys know this. I mean, Dr. B always says, hey, this is neither one of us gets paid to do this. I think the payoff we get is the fact that we get to talk to completely random strangers, if you will, in regards at a time in their life that they are looking for guidance, looking for education, looking for unconditional positive regard, looking for compassion, looking for support. And to be able to provide that to a human being that I don't know, even if it's for, a little moment in time, is something that I take honor in. And that's why I keep coming back to do it. And I know that's why Dr. B does it also.
Yeah, I love it. I keep telling Austin, who just sent me a Dr. B, what's the meaning of life? I keep telling him, dude, I need to get rich so I can just do this full time because, and it's funny, time just flew by, and there's a bunch of questions that I really want to answer, and there's even questions on here. Parham, hi guys. I don't know what to do, man. I got these awesome patients are waiting out there too. Okay, decide, Parham. Pick something to answer. Hi guys. We're gonna pick something on here to answer. I'm gonna have Parham answer. Pick one. I just feel bad leaving because I kind of feel an obligation to you guys, but come on, it's on you, Parham. Since especially
there's no really questions. I mean, people are just writing comments and writing nice things about us and with each other.
Good.
Nobody's really asking a question.
Good.
So we're not leaving anyone hanging, Doc. Even if we do, they can reach out to us. Well, there's someone here. I mean, there's no way we can get to this question, but if you know which video you have. So King Kong is asking about the Bernice method to go from, I believe, fentanyl to Suboxone or vice versa. He had a question above, but it wasn't on the topic. So do you know where you talk about that in more depth? Because I know I've heard you talk about it often.
You mean in a video where I talk about
Yeah,
it?
do you know which one it would be? It's the Bernice method, right? Is that how you pronounce it?
I think so.
Not that British. Who's that British doctor that passed away? It's from heroin to Suboxone. I remember you talked about it in one of our videos. It was, I believe, it was a British physician, and it was like a method of detoxification or a method of transferring.
We're talking about the benzos or?
No, I think it's opiates. It's from heroin to Suboxone. And he said if Dr. B has a video, I'll find it. But I do remember you shared about it, or at least you said you were knowledgeable about it. You know, for some reason I remember that. It's out of King Kong. It's out of my wheelhouse, to be honest with you. It has to do with microdosing. we're getting a little closer. He's sharing a little bit.
Talks like about heroin to bupe, and what's the question, King Kong? I mean, I do that every day.
It's a normal part of his life.
Yeah,
he had a question above. It was just way higher. There's no way I could find it right now.
Okay. Microdosing. What about microdosing? I do have a video on microdosing.
Yeah, it's bupe to cross titration. Suboxone cross titration.
It's on shrooms microdosing. Okay, look for it, King Kong. Keep moving down.
The Gold Dust woman asked if Adderall help with chronic fatigue syndrome. Does Adderall help with chronic fatigue syndrome?
No, and let me tell you what I mean by that. Does doing some crack cocaine help with chronic fatigue syndrome? Sure, it helps. You know what I mean? It's gonna wake you up potentially, but in the long run, that is not the treatment or the cure, and it can breed more problem. What's the topic? The topic is methamphetamine, detox, and everything methamphetamine. ES therapies asked if I'm Iranian, and yes, I am. ES therapies, and so is Parham. We're both immigrants. Okay, I think I gotta go. I am.
Okay, we'll answer those questions next time. We'll get to you guys.
I feel a little. Isn't crack worse than that? I love this question. Isn't crack worse than meth? How should we answer that? I love that, Jedrick. Sure. I mean, it's crack cocaine is just a cheaper version of cocaine, and I don't know if it's worse. Crack is highly addicting because of how rapidly it crosses the blood-brain barrier. Yeah, I did answer it in something else. Okay. Anyway, so YouTube, thank you. I'm sorry you can't see my lovely face today. It's probably a good thing. But you got to see Parham's. This is so much fun. I hate the fact that I gotta go. Well, it's been an hour and a half, so I feel I gave my obligation. It's just, and I keep thinking of a day that's better, but this is it for now, guys. Bear with me. We're fortunate enough to have Parham join us because he truly puts that dimension in here that I desperately need, and his output is spot on, and he is awesome, and we're having a lot of fun doing with this, and we're hoping this grows. So keep joining us. What do you want to do next week, Parham? And do you have anything to add?
No, man, nothing to add. Just thank you so much, everyone, for your participation, for your questions, for your comments. We wouldn't be here without you. It wouldn't make sense. So no topic for me yet. If you have some topic suggestions, write them on the side chat. We can still read the side chat even when we're off or put them in the comments. And if enough people have the same suggestion, maybe we can create that topic for them.
Yeah, and TikTok, same thing, man. You guys got to go on the YouTube channel, Dr. B Addiction Recovery. Me and Parham are there every Monday at 5 p.m. Totally open to design around you guys. The whole thing. This is all for you guys, right? It's meant to answer questions, I guess, Parham, right? kind of that, whatever it is that's burning you up. And when we don't know, we tell you we don't know. But the other nice thing is using Parham and I in this situation, you can get an insight and a glimpse into how we as clinicians approach things. And the whole point is to take away mystery and darkness and all things substance abuse. We love doing it. As Parham said, we don't do it. We don't get paid for it. If you want to pay us, if you want to pay me, go ahead. I'll take it, but we don't get paid for it. I'm just kidding. And we just love being here. So take advantage of it. Join us on there. If anything, press like, subscribe on the channel. And we will see you guys next week. Let me say bye to TikTok. And I I am reading all the nice things you guys are saying. What is Parham's handle? What's your handle, Parham?
I don't have a TikTok. I on Instagram, it's the 1 Minute Therapist.
Oh, that's what they mean. He's on Instagram, 1 Minute Therapist. He's also on YouTube, 1 Minute Therapist.
Yeah, same thing.
I did see all of your wonderful comments about us, and I thank you. We love you guys. It's always actually gets me, if I have a tough day or I'm depressed or whatever, seeing the support and love from all of you does a lot for me, and I'm sure Parham as well. Peace. See you guys soon. There's Parham. Can you guys see him? Yeah, Parham. Okay. Bye, guys.
Bye, guys.
Okay. And YouTube, same thing, guys. We will see you next week. Come up with your questions. And I'm going to end this broadcast. Thank you so much, everybody, for showing up.